Thanks very much. Thank you for the invitation. The mic, I think hopefully for this final talk, because you might be all feeling a bit tired, will wake you up. If hopefully it stopped working, that problem stopped. So thank you very much. So I'm a consultant radiologist in Leicester, along with, we seem to have brought up our whole crew today to talk at this conference. I'm also an editor on Radiopedia, and I'm using Radiopedia technology for this talk. Now, this is going to be interactive because I need you all guys to wake up and engage with this. Okay, so I'm not going to ask you to put your hands up or shout out, but we're going to do it online. So if you go to this URL on your phone, bit.ly/Shah-poll, and we're going to have a few questions. Okay? If you've managed to get it, can you just help out someone next to you who hasn't? I'm going to show that to you again in a second, so don't worry. And just another quick thing, which is I do a lot of social media, as you've mentioned. So this is my consent slide, if you like. So you have my consent to take pictures of my talk, and feel free to share them. Tag me in if you want, also Radiopedia, and don't forget to use the hashtag so someone can have a look at all of these and collect them together in one place. Add a few GIFs, whichever way you prefer them, if you want to as well. Okay. So let's make sure that your poll's working. So this is the first question, highly topical, Game of Thrones. I'm going to start it now, so you should be able to see the options. Okay, so you should have 4 options that you can choose. Love it, can't get enough. It's awful, I'd rather be on call. It's okay, nothing special. Or what is this? Which you could also substitute for never watched it. I'll tell you after I've got your results which one I fall into. So let's have a look. I'm surprised at that, because I thought there'd be a lot more in the top bar. But yeah, okay. So it's all working for you, right? Which is great. So I'm actually I've never watched a single minute. I'm waiting, and when it's all finished, I'm going to catch up and do it in one go. Right, let's get started. So talking about bowel ischemia, but before I go to the main kind of meat of the topic, which is small bowel, I'm going to just talk on gastric ischemia, which is something we don't actually see very commonly. And the reason is because the stomach's got a very rich blood supply, and lots of different routes of circulation, but they all arise primarily from the celiac axis. So really, to get gastric ischemia, you either got to completely occlude the celiac axis, and then you've blocked off all the routes of circulation, or have a very sustained period of hypovolemia and hypotension. So here is one particular example. Is this sound okay? Because I'm hearing some feedback. Is it okay? All right. I think it's just here. So there's a case of someone who's recently had a cardiac procedure, so a surgical procedure, and during the procedure there was a sustained period of hypotension. This is a scan done afterwards. You can see they've got the sternotomy wires here, recent surgery, and as we scroll down, we see that the stomach looks very abnormal. So there is a large volume of gas within the stomach wall. The stomach wall is not enhancing at all, and also there's quite a bit of gas within the portal venous system in the liver, which we see quite a lot with, particularly with stomach ischemia and gas in the stomach wall. And as we scroll down, actually there's signs of severe ischemia elsewhere. So this small bowel, and I'm going to describe all the signs of small bowel ischemia, is also ischemic. So this looks like a pretty horrible scan. This patient didn't survive much longer after this. The other kind of less frequent method of inducing gastric ischemia is just by gross distension, overstretching. And it becomes effectively paralyzed, and the gastric wall stretches so much that effectively becomes ischemic. So here is one example. This person attended ED with abdominal pain, and you can see that there's gas within the stomach wall. There's also gas within the portal venous system in the liver. And the coronal view really just shows you how grossly stretched out the stomach's become. So this was, it could be anything. As it happens, this was a binge of pizza. but any large sudden ingestion. So someone said earlier, I showed this case and said, oh, those eating contests that they have now where, eat as many burgers as you want. Well, that's the kind of thing that leads to this particular thing. But the main kind of problem, if you like, in clinical practice and radiology practice is small bowel ischemia. And what we really want to do is diagnose it before we get to this stage. This is really what you want to avoid, where the surgeon opens up and you've got this kind of coloured bowel. And it's really important you have a structured, systematic approach. So I'm going to talk you through the approach that I teach to our trainees. So first thing is to keep a low threshold for imaging and diagnosis. Now, partly when I talk to non-radiology EM doctors, they love this because they say, yeah, that's fine, but we want our radiologists to listen to that. And so unfortunately, the message for radiologists is you do have to image a lot to pick up this diagnosis. And the reason is because it presents in so many different ways. So there's multiple different manifestations which are very non-specific. This classic textbook of pain, bloody diarrhea, and fever is only seen in a third of patients. If we think about lab markers like white cells or lactate or D-dimers or acidosis, they're not very helpful. The white cell is non-specific. Metabolic acidosis is often late in the clinical picture. Often, if patients have been vomiting, the acidosis is blunted or they may even be mildly alkalotic. D-dimer is again non-specific, and the lactate goes up quite late in the course of the illness. There is some interest in this other marker, the IFABPs, which is fatty acid binding protein, but it's not in widespread clinical use. So of all the diagnostic tools available to make the diagnosis, CT has the highest sensitivity and specificity. As James alluded to in his talk earlier, you can actually make the diagnosis without IV contrast. So often the clinical scenario means a patient can't have contrast, not so much because of allergy, more because of these fears around renal function. So if you don't can't give IV contrast, it's fine. You can still make the diagnosis. So this is someone who presented with non-specific abdominal pain, raised white cell count, acidotic. So we were worried about ischemia, but contrast wasn't given. And there are signs on here that we can look at that tell us, actually, there is ischemia. So in the lower abdomen, we've got dilated loops of small bowel. There's increased density, congestion, and wetness of the mesentery. And it's that thing that James mentioned earlier. If you look at the bowel wall, it's hyperdense in the absence of contrast. And that's a really good sign to look for. So remember, on non-contrast studies, hyperdensity of the bowel wall is a sign of mural hemorrhage. A mural hemorrhage is one of the events that happens in the pathophysiological spectrum of ischemia. So the next thing is to actually recognize the signs of ischemia on a contrast-enhanced study, which the majority will be. And again, there's difficulty, because if you go pick up a textbook or go look in a paper, the enhancement is listed as either it's absent, diminished, lead, or increased. So it could be anything. The wall could be thickened, or it may be paper thin, so that doesn't really help. And the bowel is usually dilated, but it may not be dilated. So how do you figure out whether the bowel's ischemic or not? And the reason why you have all those different signs is because actually you need to think about the underlying cause of the ischemia. And if you think about bowel ischemia as being on this spectrum, from arterial through to venous, with a subset called mixed, which I'll go through, and then this category called NOMI, or non-occlusive mesenteric ischemia, then you can actually start piecing together and putting some signs and allocating them to these specific underlying causes. So let's go through these. So arterial ischemia is in most cases arterial, and these are the classical signs I've listed here. So if you go to a paper like in radiographics or radiology, it will say paper thin, brackets, however you may also see, and then list all the variants. But this is the predominant pattern. So bowel wall is classically paper thin with reduced enhancement, and the underlying problem with the vessels is occlusion of the arteries. And this is also known to be a dry type of ischemia until late in the process. So this is an example. So we've got an arterial phase study here, so nice bright abdominal aorta. And I just want you to look at the vessels. So we've got the celiac and the SMA, got nice enhancement, and then bang, nothing there, okay? And then if we look at the small bowel supplied by that vessel, it's dilated, it's fluid filled, and the wall is paper thin. Meaning it's thinner than you'd normally expect to see with bowel wall. So those are the classic signs of arterial bowel ischemia. And you'll see the same when you look at whether you look on arterial or venous phase studies. So this is the venous phase study, and there's very poor enhancement of the small bowel for much of its length. Okay, so this is the first question that we're going to do, first proper question. So if you go back to your poll, so the question is, what is the most common cause of arterial ischemia? Let me just turn that poll on. Okay, so is it thrombus, is it arterial embolus, dissection, or is it just stenosis? What's the most common cause of arterial bowel ischemia? It's interesting when I do this because actually as soon as I put this up, then you can see the bars swinging over to whichever was the leader at the time. But yeah, I think that's right. So embolus is the most common cause, about 2/3, and then from in situ thrombus is less frequent. Okay, so here is another case. So this is the day 1 CT. This patient presented with non-specific abdominal pain, not much going on. So we did a CT, the liver looks fine, but there's this wedge-shaped area of low density in the spleen. So splenic infarct, we didn't have any imaging prior to this. The stomach looks okay, the kidneys look fine, the small bowel looks fine. She had a workup including echo, ECG, no central thrombus was found, she wasn't in AF, she recovered, so she was discharged. She then returns a week later, this time much worse, this time also presenting with symptoms of a stroke in addition to this kind of vague abdominal discomfort. If we look at the CT this time, it's completely different. The liver is now of grossly reduced density. The spleen is now completely of reduced density as opposed to just that wedge-shaped area. The stomach is distended and now there's gas within the stomach wall. And if we go down, the small bowel loops are all distended, paper thin with reduced enhancement. So she has now developed multi-organ ischemia, multi-visceral ischemia. And if we look at the vessels, there's no contrast enhancement of the SMA or the celiac axis. So she's thrown off clots. So she was throwing off clots before, which explained the spleen, for some reason not detected, and now she's come back in, not anticoagulated, and she's infarcting all these organs. So here's another example. This person was undergoing treatment for acute lymphoblastic leukemia. So you see a grossly enlarged fatty liver, which happens as a result of some of the therapies that are given, and she had an episode of acute abdominal pain. So again, with her CT, there's a subtle area of hypodensity in the spleen. Okay, and then we look down and we scroll down and we saw this area of abnormal bowel. So just this jejunal loop here, which is slightly less enhancing when compared with the adjacent bowel and when you look at bowel loops elsewhere. So it's just this focus here. I'm going to show you on the coronal view as well. So just this very short segment, maybe 5 centimeters in length, slightly less enhancement than the rest of the bowel. She was treated conservatively, and then 3 days later, a sudden clinical deterioration. And if we look at her CT now, she's perforated, so she's got pneumoperitoneum. So she's got free gas within the abdomen. And if we look, there's a larger area of low density in the spleen, so confirming that it's infarction. And she's now got free fluid. And if we look at that bit of bowel, it looks much worse. So now we can't see any enhancement of the wall at all. There's gas in the wall, and that's extending into local mesentery. So that confirmed a small short area of arterial infarction, which is then progressed, untreated, then perforated. So the question for you is, in this case, what has triggered the bowel ischemia? So for this one, you can actually type in your answer. Okay, so what do you think has triggered bowel ischemia in this case? Okay, so one person's responded so far. They may be right. So remember what I said, she's young, she's got ALL, she's on therapy for ALL. So this requires a little bit of lateral thinking. Okay, so there's some really good thoughts here. Hyperviscosity, because as with any hematological disorder, patients are prone to becoming prothrombotic due to platelet dysfunction, red cell dysfunction, so that's true. Embolus and in situ, embolus is unlikely unless she's clotting elsewhere, but that may be because of her hyperviscosity. So in fact, the cause in her case was asparaginase, which is a therapy used for ALL and which is known to be prothrombotic. So patients on asparaginase are particularly susceptible to becoming prothrombotic, and that's used in these leukemias. Okay, so non-occlusive mesenteric ischemia, or NOMI, said to be in literature to be responsible for 20 to 30% of ischemia. I think in actual real practice I don't see that much. Classically, the bowel wall is thickened with reduced enhancement, although I think that again is disputable. Vessels are normal, so you won't find any clots or infilling defects, and again, a dry mesentery until late in the process. And this is the kind of thing you see when someone has had an event, a reduction in their cardiac output for whatever reason during surgery or during cardiac arrest, but then they recover. And when you image the abdomen, there are some features you'll see. And in the literature, it's mixed up with what's known as shock bowel, which is the appearance you get to the bowel when it's had that status. So this person's had recent surgery. There's a large pneumoperitoneum, but that's because of the surgery. There's free fluid. And the vessels are all enhancing normally, but the bowel has a very grossly abnormal look to it. So it's thickened, there's a kind of layering enhancement pattern to it, and there are some segments of bowel which are poorly enhancing and some which enhance brighter. And when you got this kind of pattern, this is typical of shock bowel. The other things on this, which people talk about shock, if you like, is a really flat inferior vena cava, so the patient's not really filled enough. There's some infarcts in the kidneys because of the hypervolemia, and if you look at the adrenal glands, they're really brightly enhancing. So these are all features of CT when you image someone after they've had a period of sustained hypotension and then you reperfuse them. That's the appearance you get. Okay, and then mixed ischemias, where there's a bit of arterial and a bit of venous as well. So generally the bowel wall is thickened. The enhancement can be variable depending on which one's predominant. You'll find both the arteries and veins may be occluded, and this is a wet type of ischemia. So have a look at this. This, again, a vague presentation of abdominal pain. There's a bit of free fluid sitting around the liver. And then I'm going to scroll down and show you and ask you what the cause is. So this is the bowel. You can see some really abnormal bowel loops here. It's thick-walled but poorly enhancing. And I'll scroll through it slowly on the axial view. And I'll show you the coronal. Okay, I'm going to leave it on that. I'm going to ask you what is the cause of the bowel ischemia in this case. Okay, so there's an adenocarcinoma, a carcinoid, a desmoid, or a sarcoma. So these are all kinds of abdominal tumours that we see. What's the cause of bowel ischemia? Yeah, I think I made that one maybe a bit too easy. Okay, so this is a carcinoid. So let's go through that again. So carcinoid tumours found in the appendix of the small bowel. but it's the secondary nodal deposit that then sits in the small bowel mesentery is the one that causes the problems and often triggers the patient's admission. So there's a large nodal mass here. They classically have this description of being cicatrizing, which means they cause fibrosis of the surrounding tissues, they draw in the bowel loops, and they pinch off the vessels. So if we look at the coronal views, you can see that the superior mesenteric vessels run right through the center of that, and then all the bowel that is then supplied by those vessels becomes ischemic. And we often see patients presenting with this particular presentation when they've got this type of tumor. Okay. Another context in which you can see the mixed ischemia is trauma. So we've got someone who's been in a road traffic accident, sustained blunt abdominal trauma, so they're restrained. You can see this bruising across the lower abdomen in a horizontal line, so that's the seatbelt sign of trauma, because that's where the seatbelts restrain them. And here we've got some free fluid pooling around in the paracollic gutters, and then there's this very abnormal length of bowel here in the right lower quadrant. It's only about 10 centimeters long, but it's poorly enhancing, it's thick-walled, and the rest of the bowel looks normal. And there's a bit of free fluid just around it in the mesentery, and it's a bit hyperdense. So remember, when you've got blunt motor vehicle accident trauma and a restrained passenger, you get application of shearing forces to the mesentery. So when you see free fluid in the abdomen, in the absence of solid organ injury or vascular injury, be really cautious and be on the lookout for bowel or mesenteric injury. When you get these shearing forces, the small vessels in the mesentery rupture, and small short segments of bowel can become ischemic. Okay, so that may be your only sign to tell the surgeon that actually solid organs are fine, there's no pneumothorax, bones are fine, but I'm really worried because I think there's signs of mesenteric and bowel injury. So if you leave that alone, patient's at risk of necrosis and then a full-on perforation. And then we move to the final category, which is venous ischemia. So in this, the bowel wall is invariably thickened. There's venous occlusion or engorgement, and it's a wet mesentery. And the key sign here is the target sign. This is what happens to the bowel. So in this particular case, there is a very large portomesenteric thrombus. There's a filling defect. And if we look at the bowel loops, you can see that these small bowel loops are extremely thickened, and you can appreciate a targetoid pattern to the bowel. So there's hyperenhancement of the mucosa, the submucosa is slightly hypodense, and then the serosa is hyperdense, and this is the target pattern of venous ischemia. And then the next step is actually you may be too late to actually pick up ischemia before something can be done, but you need to identify the signs of infarction and perforation. So have a look at this X-ray, and I'm going to ask you a question which again you can just enter your text, which is, where is the air? Okay, so where is the air on this X-ray? There's a clue that actually doesn't look too dissimilar to what Colonel Gibb showed in his last talk. Actually, not as bad, but it's still there. So there's air in lots of different places, and we'll go back. So all of these answers are correct. There's one I've not seen yet. Let's have a close look. Okay, so I think you've got, oh yeah, one person's put it, so I think someone's put liver, so whoever that was, that's really good. So there is abnormal air here. So the first thing is Wriggler's sign. You can see the bowel wall really clearly here. So that's Wriggler's sign of free gas in the pneumoperitoneum. There's also this kind of very bubbly, streaky appearance throughout, and that's because there's gas within the bowel wall, so there's extensive pneumatosis. But there's also abnormal gas up here in the right upper quadrant, okay? Linear lucencies, and this is portal venous gas, okay? So this patient's got extensive pneumatosis, pneumoperitoneum, and portal venous gas, and this is really end stage, pre-mortem kind of appearance. So we've got gross pneumoperitoneum, extensive gas in the portal venous system, and if you look at the lung windows, then it really highlights how bad the problem is with the bowel wall. So there's gas throughout the bowel wall. So we know that portal venous gas is traditionally thought to be a really bad sign, a pre-mortem sign. But increasingly recognizing it as actually a transient, non-fatal phenomenon. And there's lots of different reasons. So we see portal venous gas and bowel wall gas a lot with novel chemotherapy agents without there being actual bowel necrosis. We know that with benign gastric emphysema, it's actually, you see portal venous gas quite a lot, and again, doesn't mean much. And also, I think we're scanning people at an earlier phase of their illness, and possibly just scanning, a lot more people who have abdominal pathology than we would have before. So really, when you see it, actually the decision to operate on these patients should be determined by the clinical signs, rather than necessarily saying imaging is the final word and that patient's, going to die. So this is a case in point. This patient turned up with abdominal pains. We did a multi-phase CT, and this is just a non-contrast phase, and you can see a load of gas in the portal venous system of the liver, and if we go down, there are multiple very abnormal looking loops of bowel. So even with the contrast, there is very poor enhancement of these bowel loops. This has got classic features of arterial bowel ischemia with portal venous gas. So we thought, okay, this is it. This guy is really sick. The next day, the clinical radiological meeting, they didn't discuss him, so I asked, what happened to him, expecting them saying, okay, well, he's gone to ITU, or they stepped down his care, and they said, no, he's actually fine. He's sitting up, eating, drinking, fine. So before they discharged him, we rescanned him just to be sure, and all that gas has disappeared from his liver, and his small bowel loops have pretty much returned to normal. There's a bit of free fluid oozing to mesentery, but the enhancement's normal, and it's fine. And he was fine, and he was discharged and not been back in, as far as I'm aware. So for whatever reason, there was an episode of ischemia. There was gas translocation into the bowel wall and portal venous system, but it wasn't bad enough to cause necrosis, and therefore he recovered. You can also have some mimics of bowel ischemia, and there's lots of different things that can cause mimics. This is one you see quite frequently if you work somewhere where chemotherapy is administered. So this patient was immunosuppressed and had an episode of abdominal pain and loose stools, and this is what the CT looks like. So they've got bowel wall thickening, the enhancement's abnormal, but the history really helps, because actually the stool samples came back as positive, and this was an enteritis related to their immunosuppression. This is not bowel ischemia, and this recovered on the subsequent CT. And those are all incidences of acute primary ischemia. Don't forget, you can also have secondary ischemia, and James again alluded to this earlier. It's one of those things that you should be looking for as a complication of bowel obstruction. So I'll just show you this coronal CT. There's a large sac of bowel loops sacked and concentrated in the anterior part of the abdomen, the mid and lower abdomen. And if you scroll through these, you can actually see the eye of the storm just through the center there, which is relatively clean fat where the vessels are traversing and then coming to a pinch point. So this is an internal hernia with loads of bowel loops trapped in, causing bowel obstruction, but also secondary ischemia. And the signs we're looking for again with this are mesenteric edema and congestion, and all this kind of generalized wetness of the mesentery. So when you're reporting this, not only are you saying it's an internal hernia, there's obstruction, but as James said, report the adverse features, which include mesenteric edema, which is a sign that they need to do something sooner rather than later. Okay, and then large bowel ischemia generally have less of a diagnostic issue with. So remember that you've got the middle colic artery, which is a branch of SMA supplying most of the right colon, and then the left colic artery, which is off the IMA. And at the splenic flexure, there's a variable supply and overlap between these two territories, and that's generally where we see problems when people get arterial large bowel ischemia. You'll see low density thickening of the large bowel from the splenic flexure down to the descending. It's classic, we see it quite a lot. It's often misreported as inflammatory or infectious colitis. But if you see that distribution with that pattern, with the thickening and low density, then that's a typical feature of large bowel ischemia.